Welcome back. This is part 3 of temporomandibular disorders and orofacial pain. We're going to finish up with neuropathic pain diagnosis and treatment. And on to neuralgias and neural disorders. We're going to focus on mainly one big one, and that's this trigeminal neuralgia, also called tic douloureux. This is the most common of the facial neuralgias. This is extreme, severe, shock-like pain, at least 9 or 10 out of 10 pain. Limited to one of the areas of the trigeminal nerve, usually the maxillary nerve or the mandibular, a lot less common for the ophthalmic nerve. This is significant pain to just light touch to one of these branches. In fact, this is an important point to take home from this. It has one of the highest suicide rates of any disease. So it comes on suddenly, initiated by light touch to a specific and a constant trigger point. Extreme paroxysmal, meaning it's coming on all at once, lancinating. And the duration, fortunately, lasts less than a couple of minutes, although the attack may have numerous short repeating spasms. Then several minutes after that, there's a refractory period in which it can't be restimulated. And so knowing that could be a diagnostic help. So I know a lot of dentists like to diagnose trigeminal neuralgia whenever someone comes in with pain and we just can't isolate it to a tooth. But if you look at the diagnostic criteria, it's probably a little more rare than that. And then another diagnostic criterion is the pain is dramatically diminished with carbamazepine or another anticonvulsant. If that dramatically reduces the pain, then likely it is trigeminal neuralgia. And these patients are going to require medical treatment. This is beyond the scope of dentists. There may be neurosurgical options. Sometimes it's caused by vascular compression or neural compression inside the skull. So they'll do an MRI, a very detailed MRI of the skull base, showing if it looks like there's some compression, and they can do decompression to hopefully help. And so that's the takeaway from this. Your job as a dentist is to rule out odontogenic sources, which hopefully we're pretty good at by now. And then we've talked about the sinus lecture, see if it may be a sinus pain, maybe a referral to ENT, or in this case, a referral to their physician, and get some further imaging to really determine what's going on. And now we're going to get to some growths and tumors, which one big one to know is condylar hyperplasia. This is just a developmental abnormality. Results in a large deformed condylar head, although it does mainly maintain the same shape as the condyle. If you look at this, it just looks like an extra long condylar neck, fairly wide condylar head compared to the other side, and this is more normal. And so that affects that entire side of the mandible. The ramus is going to be longer, so everything is longer and it's going to be shifted to the other side. If you notice that leftward shift of the mandibular midline. And so the big question may be, next we're going to talk about condylar hypoplasia. Is it hyperplasia of one side or is it hypoplasia of the other side? And look at which one looks more normal. This just looks like an overall large mandible. Another thing that's not mentioned here is could it be hemifacial hyperplasia, which we talked about in another lecture, and that affects more than just the mandible. Here in the AP-Ceph, you can really appreciate that leftward shifting, the really long ramus. And then we're also going to talk about osteochondroma, which this looks more like a benign tumor. An osteochondroma is not going to just maintain that normal condylar outline. It's going to look like a little bit abnormal growth, even though it should be well defined and could be confused with this. And as we just talked about, condylar hypoplasia. So does this look similar to that last case? Larger on the right side, smaller on the left side. But in this case, if you just compare with averages, it's because the left side has hypoplasia, very short neck, and so fairly short condyle overall, short ramus height. This can just be congenital developmental, or it could be from an acquired disease that affected the condylar growth. So just like the last one though, it's going to maintain normal shape and structure of the condyle. And now we have deviation toward that side because it's smaller. And so what do you need to be thinking of when you do see one side just has a short, small condyle? Well, if it's a young patient, is it juvenile arthritis? Look for signs of destruction, those signs of degenerative changes that you shouldn't see in a child in most cases. Then same thing with degenerative joint disease if you find this in an older patient. So sclerosis, flattening, osteophytes, erosions, all the typical signs of degeneration. And we talked about differentiating from hyperplasia of the opposite side. And so here's two major differences I might not have mentioned. In hypoplasia, think of pronounced anagonial notching. And then in hyperplasia, think of potentially downward bowing of the inferior border. And then this is a somewhat rare one, but you can have coronoid hyperplasia. Some patients just seem to have large coronoids, but if it extends more than a centimeter above the inferior rim of the zygomatic arch, as we see here, this is probably about 2 centimeters, then it's probably a case of coronoid hyperplasia. They can also get osteochondromas, osteomas, different growths on the coronoid that cause that. All right, Arnold may argue, but sometimes it really is a tumor. So as we get to tumors, These are just general features: slow growing, swelling, and then decreased range of motion, malocclusion. Just like we were talking about with inflammation, when they're just sitting at rest, there may be deviation to the unaffected side because of that growth, because something is creating a mass in there. So it's pushing things toward the other side. But as they try to open, they may have limited mobility on the side that's affected. And as they open wide, it may deviate toward the affected side. So keep that in mind. So it looks more irregular compared to the things we just talked about. Instead of a hyperplasia where it maintains the normal outline, now you've got an actual growth, a benign tumor. And so it looks like something growing off the condylar head or wherever it happens to be, the coronoid. Almost always these are going to be unilateral. And so what we mean by irregular is maybe more bulbous or pedunculated instead of that nice smooth shape. You see something growing off the condyle or the coronoid process. And so hopefully you remember osteomas now. Typically those are radiopaque. We have the ivory osteomas or the mixed osteomas. And so that should be on your differential. But actually more common in the TMJs at least is the Osteochondroma. That's the most common benign tumor that you're going to see in this area. But those may be tough to distinguish. As we said, there may be compact or there may be spongy or mixed osteomas. So whether it's one or the other, we're not going to be able to decipher that from imaging. And so this just looks like a growth. It almost looks like an osteophyte, but it looks like it has normal marrow space. But it looks like something growing off the anterior border of the condyle. And this is an osteochondroma. So by far the most common, if you see something like this, safe to say likely an osteochondroma, but could be one of these other things. Langerhans, usually radiolucent. I said I usually think of that as a malignancy, although there is a benign variant. Osteoblastomas, so we've talked about those as one of our non-odontogenic lesions, so it could occur in the TMJs. Then less common benign tumors are going to be chondroblastoma, fibromyxoma, and any number of non-odontogenic benign tumors or cysts. As far as malignancy, you can have a primary or metastatic tumor. It is somewhat rare to have a primary tumor inside the TMJ, but as we talked about sarcomas, osteosarcoma or chondrosarcoma can occur in the TMJ. Then other more joint-specific ones, synovial sarcoma or fibrosarcoma can occur anywhere in bone. And then notice what's not on this list. The most common oral cancer, squamous cell carcinoma. Why is that not even on our list? I suppose it could occur there, but we talked about squamous cell carcinoma so rarely occurring from within the bone, it's an epithelial tumor. And so it didn't even make our list of top 5 differentials for primary malignancies in the TMJ. And what do we mean by extrinsic? Well, salivary gland tumor, which could come from the outside and then penetrate into the TMJ region. It could erode through the bone. Rhabdomyosarcoma is a malignant tumor of children. There could also be a carcinoma from the skin, ear, nasopharynx, somewhere just extending into the joint and creating joint problems. And now we're to metastases. So remember our big 5, BLT, kosher, pickle. Then I added 2 more here. What are the chips? So we have breast, lung, thyroid, kidney, prostate, colon, and multiple myeloma can affect the jaws as we've seen. In this case, what do you think is going on here? It looks fairly well defined, but there are some ragged borders. What do we notice here? I haven't talked much about identifying fractures, but there's a step defect here. There's a pathological fracture. That tells you, that could be a benign thing causing pathological fracture, but a lot of times it's very erosive. A lot of these signs are just aggressive. The fact that it looks so irregular here. Well, if you knew the history of this patient, he had a history of lung cancer. So this was a lung cancer metastasis causing the pathological fracture. All right, these may start as asymptomatic, then over time develop TMD symptoms. In most cases, we hope that malignancies are ill-defined, right? But what do we see here? This is a chondrosarcoma that looks to me more like a benign lesion. It looks well-defined and enlarging. Here we see a little bit of calcification in the soft tissue, though. There's a soft tissue extent of this tumor. And if we see this in other windows, you can appreciate that even more. But what tumor causes calcifications? This is our chondrosarcoma. And so to differentiate that from other things that I'll talk about that create calcifications inside the joint, look for bony destruction, look for signs of malignancy. And so it can look a lot like a severe degenerative disease. But yeah, you look for those signs of irregularity. We don't have the teeth to look for that PDL space, but just look for those irregular signs, tissue destruction. DJD is not going to create a soft tissue mass. Here we see what looks like maybe this could just be large subchondral cysts, but there's a soft tissue mass creating calcifications out here, and that's what tells you it's a lot more than just DJD. All right, quickly on dislocation and trauma. I'm not going to spend a lot of time on this. You'll cover more of this in your oral surgery courses. And this being an MRI, maybe you have no idea what you're looking at here. This is brain tissue up here. This is the glenoid fossa and the articular eminence. And the condyle is way out here. So I think I've said this before, but think of MRIs as the reverse of most imaging we see, where marrow space is going to be fairly light. It's got fat and fluid in it, whereas the cortical bone is going to be very dark. So look for dark outlines for cortical bone. And so there's our TMJ. So there's our mandibular condyle, and it's just very far forward past the articular eminence. So this is dislocated. Once it's beyond about a centimeter of the crest of the eminence, that's a dislocation. That's excessive mobility. If they do dislocate, then they're unable to close the mouth. You don't want to leave them in that position very long because that's really putting strain on the muscles, going to create muscle spasm, obviously some pain. So if you do see this may happen as dentists. We've got patients with big bite blocks in their mouth for extended periods of time, and a patient may lock open. So you've got to know how to reduce this. And to do it, you got to put your thumbs on their molars, their mandibular molars, and push down before you push it back. If you just kind of imagine the shape of the joint, you've got to push that condyle down so it can get over the articular eminence and back into the glenoid fossa. So if you think of your anatomy, it's not too bad. Sometimes it does require some force. If you're unable to do it, that is an immediate emergency call. Someone's got to reduce that as soon as possible. All right, talk a little bit about fractures here. Condylar neck kind of being the classic site. You can have breaks in the condyle or just under the condyle. It's just more common in the condylar neck. And so look at the cortical outline. When you're looking for any fracture, any sign of trauma, look to make sure those cortical outlines are smooth and continuous. I mentioned a step defect on one of those images with the pathological fracture. Also look for the condylar head to be displaced. Sometimes it's pulled by that lateral pterygoid muscle. And so there's a rule that's the guardsman's rule. A blow to the chin, suspect a condylar fracture, and a lot of times bilateral. Think of the mandible along with the joints, it's kind of a ring. And if you break a ring, a lot of times there's a fracture contralaterally. And so if you have one condylar neck fracture, look for a contralateral parasymphyseal fracture, so just off center in the mandible. And of course, they may have pain, limited opening, severe loss of function if there is a fracture. Pano is a great screening tool, but CBCT is really going to tell you in 3 dimensions where things are and where things are displaced. A lot better look at if there is a fracture that might be small and missed on a pano. So here's a couple examples. Maybe we expect fractures to be a nice, thin, radiolucent line, and that doesn't always happen. Why is it radiopaque here? Here we've got actual displacement of the condyle. It's likely going to be pulled medially, so it's probably pulled medially inside the ramus. And now you have an overlap of the condylar neck and the ramus, and that's why it appears radiopaque, because the x-rays are going through more objects now. And there is a step defect here. Look for those nice smooth outlines. Here's one from the AP view where you can see the condyle is just bent over medially. And so treatment for these, there are some options. You could go in and do an invasive surgical repair, but I've seen in a lot of cases of these where they just leave them to heal on their own. The patient's obviously going to be in discomfort for several weeks while it's healing, probably going to require a soft diet. Sometimes the jaw is wired shut, or maxillomandibular fixation it's called, and just allowed to heal that way. And what do we mean by ankylosis? This is fusion of some of the joint components. It can be true bony ankylosis or just fibrous ankylosis, fibrous tissues that ankylose. And that can be caused by trauma, infection, or those various types of arthritis that we've discussed. And this is going to progress slowly over time as you think it kind of grows from more fibrous ankylosis to maybe true bony ankylosis. Typically the ankylosis itself isn't painful, although the underlying cause may cause pain. And then on imaging, for fibrous ankylosis, that's going to look like jigsaw puzzle, meaning the different parts of the joint are going to fit together like a jigsaw. The condyle and the articular eminence, instead of being nice and smooth and round, they're kind of irregular. Their undulating patterns are complementary to each other, so they kind of fit together, and we'll show you an example of that. Bony is when the space is completely obliterated and you see an osseous bridge between the two different joint parts. The condyle is completely fused with the articular eminence, or the glenoid fossa. In these cases, you also see degenerative changes. Well, let's see what some of these look like. Okay, here's that jigsaw puzzle pattern, and we call that fibrous ankylosis. They're probably going to have some limited mobility here. You can also see the signs of degeneration, severely sclerotic condyle. Here we see that same thing on both sides. This is a case of rheumatoid arthritis, where it's really destroyed the mandibular condyle and really caused quickly progressing degenerative changes. And what the arrow's indicating here is an osseous bridge. So once you start to get osseous ankylosis, then you've really constricted the mobility. Patient might not be able to open at all. And here again on the right side, we see this osseous fusion or bony ankylosis. All right, I'm going to get a little bit into treatment, but not too deep, but just kind of talk about the major, most common diagnoses and different forms of treatment we can start with. So we're always going to begin with conservative, reversible treatments, and that includes patient education, habits. Again, remember at the start of this lecture, we said the mystery is in the history. And so if you know the history of the patient, you can hopefully uncover some of these habits that are contributing to it. And some of the education may involve changing their diet for an extended period of time, doing some stretching on the joint if it's just a muscle thing, rest, joint immobilization, cold or heat can help, specifically when it's a myofascial pain. Occlusal splints and adjusting can help in a lot of cases. And then maybe something we don't do enough as dentists is work with physical therapists. Work to get them with better mobility, better function of the jaw joint. Then these are the typical medications, starting with just NSAIDs that can help in degenerative disease or muscle pain. And in some cases, when they do have very specific muscle problems, you can prescribe muscle relaxant. Back when I was treating it, it was always Flexeril that we used, but there are different options: methocarbamol, chloroxazone, in some cases a benzodiazepine, and then also glucocorticoids. And then remember, this is a key point: surgical intervention is reserved for only the last resort, severe cases, usually after years of unsuccessful conservative therapy. And so just summarizing that all together, for your typical pain, whether it's joint or muscular, whether it's arthritis or myofascial pain, consider a stabilization splint. Specifically, if you know that there's some nocturnal bruxism, then they can wear that at night, and that'll help a large majority of these patients. Education, habits. Do they chew too much gum? That's one of the problems I have. Do they have a habit of biting nails, pencils? Does it occur during times of stress? In some cases, a stabilization splint during the day is going to help. Do they need to change their diet, softer diet, at least for a couple weeks until they start feeling better? And then this one's more specific for when it's myofascial muscular pain. Heat and cold muscle relaxant can help. Obviously, if there's a tumor, that tumor needs to be removed and reconstructed as needed. And then specifically for septic arthritis or inflammatory arthritis, antibiotics are going to be needed. And if it's really aggressive, really destructive, potentially surgery. And this is your occlusal splint or night guard, bruxism guard, whatever you want to call it. And this is effective in up to 90% of cases, can help with arthralgia, so joint pain or myalgia, muscle pain. So it decreases that masticatory activity. These can be auto repositioning or anterior repositioning. Auto repositioning just meaning it's not programming the bite to be in any specific direction. You try to get even occlusion all throughout the bite block with some canine guidance here. That's what's showing in blue. And so if you haven't learned to do those, you should. As we said, this can help a large majority of these patients with TMJ pain. I think between that and getting to their history, really getting down to the cause of their pain or symptoms, eliminating that, you can hopefully successfully treat a large majority of these patients. And those where it's more specific finding, or if it's a tumor or something that requires further referral, then you can make that referral. And just one slide on joint surgery, because you'll get this in your surgery course. And these are just organized from least invasive to most invasive. Arthrocentesis is just flushing out the joint with port placement. And so a syringe is placed anterior and then posteriorly, and that's just lavages and washes out. That breaks up some of the fine adhesions. That can help in a lot of cases. When someone has, specifically when it's disc adhesions and the disc is locking, that can break that up and help it move more fluidly. And then arthroscopy is just a surgery with a camera, and that's used in a lot of cases to do disc repair. But prior to repair, you can reposition the disc. Remember, we said the disc should be adhered to the mandibular condyle, and if that slips forward, that's what's causing the problems. And so if that is repositioned against the condyle, so it would just stay against the condyle, that can help in a lot of cases. Or the disc may be ruptured. It may be bent, folded over, in some cases eroded. And so that can be repaired, or if it's beyond repaired, then removal of the disc completely. We talked about disc dislocation without reduction. Sometimes it's the disc creating the lack of mobility in there. And so if that disc is removed, that can help. Then the next step up is a modified condylotomy, removing part of the condyle, and then removing the entire condyle and just a total joint replacement. But these are saved for last resort. And why is that? It's because they're somewhat unpredictable. They may not end up in a better place than they were before. And so really just a patient that really has no other options. Are you going to jump down to these more severe, more invasive types of treatment? All right, so that does it for our TMD and orofacial pain. Like I said, we'll go more in depth in some of these things in your skeletal muscular course. All right, so we'll see you on the next one. Thanks.